cardiovascular system.
Why you want to do cardiovascular system?
To rule out
Through out what?
heart failure.
Heart failure. Where is that peak on this patient? Fifth intercostal space, lateral, anterior axillary, mid axillary line, which one? So epic displaced or not displaced? Tak boleh Aisyah. Tak boleh display. If anterior axillary line is displaced, isn't it? The epic display. Okay. Now you can get answer why doctor advised to restrict the fluid because heart failure. So this patient could have heart failure. Patient with heart failure can be the bronchi also because of bronchospasm. Okay, bit of the theory. Those who already in my club, I've done my club. Okay, what in patient with the displaced epic that indicate cardiomegaly, isn't it? Okay. And this patient, let's say patient heart failure. When you auscultation, when you do auscultation, what abnormality that you expected to find? Patient with cardiomegaly. Okay, first and second nak sound first. Any patient just don't worry about that. The patient with heart failure, dilated heart. Okay. What happened to first sound? No valve normal. What happened to first and second sound? Valve normal. What is the first sound you do? So I told you valve normal, the first sound normal. Answer lah, it's senang kan? Normal S1, S2 because the valve is normal. Simple. But patient with valve abnormal, the first and second sound will be abnormal. Because patient with heart failure, the valve is normal. Okay, so do you expect any murmur with patient with dilated heart? Do you expect any murmur? Hands up. Dah pergi my class. Ni dah nak habis tahun ni. Siapa dia? Patient with dilated heart. Do you expect any murmur? I thought few of you discuss heart failure kan? Kau sikit, Edina, mana nama you lah? Edina, I ingat lagi nama you, okay.
Systolic murmur without radiation.
Okay, explain to me why this patient with dilated heart, you expect persistent murmur at lateral area, isn't it? Why? Bangun kat ada dah, kau bagi kita, okay. Stand up, why?
I remember in functional valve deformity, so there is radiation. So
when the heart is large, dilated, the veering also dilated, but the valve is normal. So you expect incompetent. So we call that functional incompetent. Functional mitral incompetent because the valve is normal. So in functional mitral competent, the first and second sound is normal. Okay? You don't expect any thrill. You don't expect any radiation because the valve is normal. Simple as that. So in patient with dilated, without valve lesion, you expect pentasteric murmur at mitral area. With normal first and second heart sound. But if patient have valve lesion, have pentasteric murmur, what happens to first heart sound? Because that pathological mitral incompetent, because valve, because the valve. So what happens to first heart sound? The valve cannot close slowly. So simple. I don't want you to remember. I want you to reason out and find out the reason. That is, please develop that. That's culture now. Develop this ritual now. Because I'm sure 100% of you will go for further study later. Develop now. Don't try to memorize. Patient mitral competent serve as first, second sound, radiation to the motor, without knowing what is behind. Okay? So please develop that. Okay? How to develop? You always ask yourself why. And then you go and find out. Either you ask a lecturer, you read, something like that. Okay? Okay. Lung kat CVS, you have done that. Okay. Okay. Let's say this patient has acute exacerbation asthma. Patient doesn't have any history intubation. And how many admissions so far? Okay. Does the patient require steroid administration every time of admission? So that's another history that you need to give. Because if patient requires steroid hydrocot during the admission, this time also the patient required. So easy terminal. Okay. Okay. After taking history, after do investigation, and you sure this patient have acute exacerbation asthma. Okay. Patient in front of you after taking history, physical examination, how are you going to treat this patient, Isha? Exactly. If you have me as examiner, okay, acute exacerbation, I will ask that question. Okay, you are onco doctors, A&E. You have patient with acute exacerbation asthma after taking history. How are you going to manage? I give a clue, I give a tip for you, okay? Always start after making sure that this patient stable, vital sign, I will start with this treatment. What? You need to rehydrate IV3, 2. And then you have to release the obstruction. How are you going to release the obstruction? You give bronchodilator, but don't give nebulizer. Okay? Give bronchodilator. You nebulize the bronchodilator. My next question is the same question I will ask many in the exam. When the time frame that you expect patient to respond with bronchodilator? What is the time frame? Huh? What?
15 minutes.
Ni lama. Okay. Patient should respond almost at between 5 to 10 minutes only. Okay. Why is very important for you to know the time frame? When you give patient a conventional therapy, you must know the time frame. That is always I repeat in my class, isn't it? Okay. You must know when the time frame that patient should respond to directing patient with heart failure, for example. When patient to respond to bronchodilator, patient with acute exacerbation of asthma or COPD. Okay? When patient should respond, if patient with infection malaria, typhoid, for example. Okay? Community acquired pneumonia, for example. You give antibiotic. You must know ideal time frame. Okay? The reason is that if patient do not respond to according time frame, always ask yourself whether I make a right diagnosis or not. That's important. Okay? When you ask yourself that, then automatically you will go to review back the history. Review physical examination. Review investigation. Okay, in this case, let's say you give bronchodilator, you nebulize bronchodilator. Patient do not respond to time frame that you expected. Let's say after dry off all the bronchodilator in the chamber, dry, patient still do not respond. Okay, must be something wrong with it. Okay, you can repeat, of course, but at the same time, you must ask yourself whether I make right diagnosis. In this case, because different diagnosis is heart failure, you go back and review. This patient could have failure instead of acute exacerbation asthma because presentation is the same. Okay. I give a real story, okay? District officer somewhere in, admitted, always no case of acute exacerbation asthma, no case of acute exacerbation asthma, no case, and patient finally died of heart failure. So the message that don't accept no case. you must find out, is it really known case or not? So another word is you have to get this. Okay, it happened that the son of that deceased is a doctor too. So it's what happened if it happened to your father? It happened to your parent. Okay, so some examiner allergic with the word the known case. Okay, so it said that he was diagnosed as rather than known case. Because known case, automatically you won't bother, just accept whatever written in the note. You find out, is it really known case? Okay, it's better. Was diagnosed 10 years ago when he presented with acute episode of the. Okay, so apa lagi kita lupa dah. Okay, so time frame. Okay, let's say in this case, you give twice bronchodilator, nebulized bronchodilator, patient will not respond. 10 to 5 minutes. Go back to the history. Whether this patient really have acute extubation or heart failure. Okay, after reviewing history, physical examination, investigation, confident this is acute extubation asthma. And ask yourself whether this patient has complicated asthma, that acute extubation asthma which do not respond to bronchodilator. So when you must know what are the conditions. I already mentioned one tadi kan. Apa dia? What patient do not respond to bronchodilator? I already mentioned one tadi. Dehydration. Second one? Apa lagi? Yes, acute. Not that acute. This is difficult to stabilize, but do not respond to treatment. Apa? This is very important. This is you misdiagnosis is life, you know. Asthma, complication asthma. Apa dia? Kena tahu lah complication asthma. Pneumothorax. If you think that this patient pneumothorax, of course you go back and examine. Look whether the patient shifting of the sternum. Okay? Let's say the patient has shifting of the sternum. You think that pneumothorax. You order. What do you order? What investigation you order? Chest X-ray. But chest X-ray, by the time chest X-ray arrive, portable, patient become blue already. Isn't it? So what do you do? Huh? What? Patient become blue. You order urgent X-ray. What? Huh? Huh? Of course, you diagnose already, pneumothorax. What do you do? You white bone needle, isn't it? The tracheotomy because you do white put in the needle. Where do you put the white bone needle? Huh? Which space? What second space? Because the attach go to flow, isn't it? Huh? So which part? Okay, second space. Is it superior to the ring or inferior to the ring? Inferior. Where is the vascular bundle of the ring? Inferior or posterior? Anterior. Inferior, isn't it? So don't put inferior because you might injure the bundle. So that is the purpose of doing anatomy. Okay, put superior to the ring, isn't it? So that is the super bundle. So that is very important to have this knowledge because sometimes in aeroplane, okay, patient has sudden onset of pneumonia, you examine is pneumothorax. Yeah, simple. Take the needle, put. Okay? And next day you came out in the newspaper that is okay? So that is the emergency, okay? Okay. Let's say this patient doesn't have pneumothorax, but still do not respond. And patient now, the pulse rate become 120. Patient tend to blue now. So what you do? What do you do? Of course you add medication, steroid, everything, okay? What do you do now? Time to ventilate. And the most likely cause patient do not respond to bronchodilator because of thick mucus. So when you ventilate, when you intubate the patient, you can suck, remove the flap and hopefully nebulize bronchodilator with. So that is the treatment. Okay, if an exam you reach at the stage of treatment, you selamat. I mean, the mark you can get, you score the mark in history, you score mark the physical examination, you score mark the diagnosis, you score mark in the investigation. You got, I mean, all the section in the management, you have a mark. What worry is, you start with physical examination or diagnosis, and you miss a lot on investigation and management. Okay. And when you presentation, you continue present until examiner stop you. Okay, let's say you present history, the examiner doesn't, you go to physical examination. Doesn't stop you some more. Diagnosis, differential diagnosis, doesn't stop some more. Physical investigation and management. Okay? Usually examiner don't disturb you unless you make a gross blunder. They allow you to present. At the end of presentation only, they start to ask question. But depend on the style of examiner. Okay? Okay, cukup lah. Okay? Okay, I got you. I hope you have some insight. Some insight how to present relevant history, physical examination, order investigation appropriately, and management. And no more such routine anymore at this stage. Okay? In exam and when you work as house nurse. Good news that Ministry of Health, I mean the waiting list to start husband currently is 6 months. But Malaysian Medical Council and SPA and Kementerian Kesihatan have come out with conclusion that Ministry of Health will offer a conditional offer of work job to you during final year examination. That's why have Ministry of Health coming to you already? You will receive conditional offer job with Kementerian Kesihatan provided you pass the examination. Then only that offer. So that with that offer, you can go and register with Ministry. With the MMC, where the result. So we expect your waiting list is not more than 3 months. Okay? But I know that some of you want to rest 1 year, 6 months. Okay? So please do that because your knowledge, your skill will deteriorate. Okay? Start as soon as possible. During my time, not even next day, past 1 week later, if you have to start. Okay, so don't try to. Okay. Oh, good luck. Okay. Yeah. Question.
Can I ask a question about the former Prof? Just now Prof mentioned it's because of the dilation. We have pancystolic trauma and mitral failure, but it doesn't radiate to the axilla. From what I read from mitral reverting patient, the radiation is because of the location of mitral valve. So why does it not radiate from? Because technically it's incompetent because of
The past is normal. The past is normal.
Then why is there?
Huh?
Why is there? Because
Mama, you know the valve is attached to the AV ring, isn't it? Okay. When the heart dilate, let's say the AV ring 2 centimeter. When the heart dilate, they the wall only dilate. Is AV ring also dilate, open. From 2 centimeter jadi 2.1 centimeter something like that. That cause incompetent. So we call that functional incompetent because the valve is normal.
so the radiation is not there because the valve is not floppy.
Yeah, not floppy. Normal. Okay, and that's why you don't expect trail. The murmur is not loud enough. Okay. Okay, thanks. Okay, good luck.